Hello.
Hi, Tandy.
Hey, how are you?
I'm good, except that I got COVID.
So you
Is
stay
at
at
home.
home?
Uh, Yeah. How's your new place?
New place is good. The background I use is actually from the living room.
Oh, is it real?
It is.
Wait.
It's not real, so I took a picture and I put it up as a background.
Oh, I see. Oh, that looks very nice. It looks
Yeah.
like a high rise.
Yeah, it's high rise and very nice view. As you can see in the background, there's a lot of greens.
Nice, nice. And the um nice high ceiling glass window.
Yeah, from from the floor up to the top. But I'm sitting in my bedroom, so I just need to use some virtual background.
But you chose to use your living room picture.
Yeah, because it looked nice though, so I just put it
Yeah,
up.
I agree. Yeah. How was your move?
It's not too bad. So I got here on the 9th, and things are fine. I just got my license plate and everything, so nothing much.
Mm,
How things on your
oh,
end?
this it kind of sucks. I didn't know that COVID can still make people sick. I was more like I was one of those who say like testing for COVID at this point is irresponsible because you have to make other people cover for you. But we had an outbreak, I think, in the ICU,
Of course,
and
I
and
think it's
uh
still ongoing.
and yeah, and then I had to cancel my board exam that was yet tomorrow.
Oh, so you're gonna have to
Yeah.
reschedule at some point, huh?
Yeah. So luckily, Elizabeth and Rebecca were very supportive, and they said it doesn't really change anything if I do it this year or next year. And then the board also suggested they wouldn't force anyone to cancel it for COVID at this point, but they strongly suggested it would be responsible, but it's up to you. And they also gave me a full refund.
Okay.
Mm.
Well, at least you
Mm.
get a refund. Otherwise, it'll be a huge mess.
Yeah, right. Yeah, right,
Yeah.
right. And yeah, it's better to get this done, but also like I cannot sit in a closed space with a mask on for like 9 hours.
Right. And I
Mm.
think it's all gonna be cold in there.
Cool.
Typically the room is pretty cold. If you go for a board exam, you
Oh
need to get a
yeah.
sweater or something.
Oh, I didn't think about it. Yeah, that's true.
I did it
And
yesterday, and
then
shockingly, it was
mm,
hot. It was like steaming hot in
It
there,
was
which is
hot.
worse. Yeah, it was bizarre. Yeah.
was it? How close are you with the other test takers?
I mean, there's like 20 people in a room, and you
Oh,
have people like there's no spaces in between you. They're just in like the cubby to your left and right.
I see. Yeah. And that's kind of what I was worried about, just all the other doctors. And then it turns out there happens to be an outbreak coming from there. And then they look at people, and then I was supposed to be on home quarantine. Then bad publicity or something. I was just thinking too much, but I think it was a good decision.
Yeah.
Mm.
Well, you get a good score next time. So this year, just relax.
Also, I think my score will be actually worse. Maybe I will do better on the concrete section. Yeah.
It's.
Oh.
I think it depends because sometime when doing more pulmonary, you are getting into more of the newer paper and stuff like that, which for the medicine board they haven't updated yet. So you end up
Mm,
answer something too new for them, and that's not correct.
uh,
Which is like it's not the way it's supposed to be, but it is what it is.
uh, if you know too much, then you
Yeah.
actually do worse on a simple exam.
Yeah, and sometimes the ICU stuff that we do is not straightforward. So if it's not straightforward, then you end
Mm.
up using your judgment more than the evidence out there. which sometimes you cannot use evidence because the situations are different, right? So if you answer based on your judgment and the thing that you do in your ICU daily, it might not be the correct answer. So that's one of the things.
Yeah.
And there's been a protest like this every year from the subspecialist, like, hey, this is the way we do it in real life, but well,
yeah,
something.
I guess though, like it doesn't really matter, right? Like it's more than 90% of people pass, and it's actually just for the title of it, right? So it's not like you have to compete with others for a better score. So
that is true. Well, I think we're gonna wait for maybe until 12:10, and then we can start. I think I'm gonna be doing.
I know Michael's joining too, so he should be here momentarily.
Okay, sounds good. There are actually 2 PowerPoints that I can go over with, but I think we should choose one. One is more of an overview of everything, and it's kind of board style questions that I have at the end. And another one is actually the case base. The entire thing is the case, which I gave the talk to Spalding. But it might not be going to every little detail, so whichever one you like, I can just pick one of them. Hey, Jose, how are you?
Hi, Danny. Good,
Hey.
and you?
Good.
Sorry about joining late.
Yeah, no worries. Well, we have time, so I'm gonna wait for maybe a couple more minutes and we can get started. But let me start sharing the screen. Okay, you seeing this one?
Yes, we can see.
Okay.
yeah.
So this one is actually an overview of everything, but it has some question at the end. We can actually start with a question. It doesn't have to be the question at the end. And if you go with the other one, which is this one also has some overviewing of how to take care of lung patients as an inpatient. This is a patient we send to Spalding, and they often have a lot of questions like how to take care of these patients, what should we be looking for, and I have my own approach to all of these patients. So this is like case-based. It's a real case that we send over there. So you can pick whichever one you like.
Sophia, you decide.
I have no preference.
Well, if that's the case, I'm going to go with the first one since I opened it first then. Okay. I'm gonna... All right. So here's the thing. So in overviewing, what we need to know about is the process from the get-go. So first of all, you need to make sure you know how to refer the patient. Who should you be referring? And typically we categorize these into 4 categories. Number 1 is obstructive lung disease, which is typical COPD. Number 2 is pulmonary arterial hypertension. Number 3 is more bronchiectasis and CF. And number 4 is pulmonary fibrosis, which these 4 indications I put up there is the more common one that we usually see. When we evaluate these patients, we often look for contraindication. But all in all, we weigh whether the risk of doing transplant is going to be outweighing the benefit or not. If doing transplant has more benefit, then obviously we're going to do it. When you refer, we need to know like what are common contraindications to referring. Then I'm going to go into the details about that. Once we evaluate the patient, we'll do a listing and we'll calculate something called composite allocation score. These score can tell us how sick the patient is, and then that leads to expedited transplantations. So if the score is pretty high, then you get to transplant a lot faster. At the time of transplant call, we evaluate the donor and the recipient, both of them. And if they are good, then we go for a lung transplant. We're gonna have some talk about surgery, both the immune suppression, infection control, prophylaxis, and other common situations that we usually face, and what are the differences between the normal lung and the transplanted lung. And obviously after transplant, we're always concerned about like rejection and other stuff. So who are we gonna be thinking about listing? We need to know like the risk of dying without transplant is greater than chance and highest chance of survival after transplant. So obviously if you're gonna die faster, but if you do transplant, you survive, then that will be the thing that you're gonna looking for. I have some definition out there, as you can see down here, but that's something kind of subjective that we evaluate every patient as well. Here are some of the outline. There are actually more to this, but for COPD, typically these patients, they wait on the lung transplant list for a very long time. So you want to send someone who actually is starting to need oxygen. When they start to need oxygen, that's when you think about referring them. But when you refer, you need to know like what are contraindications. Let's say if they're still smoking, we cannot do that. They need to stop smoking for at least 6 months. This includes any vaping or nicotine replacement therapy as well. So lozenges, patches, those kind of things are also counted towards nicotine. So you need to stop them 6 months before. But you can refer them before that, but we just have to tell them, hey, you're not ready to be listed if you're not 6 months out of your last nicotine. And we're gonna be checking for that as well. Pulmonary hypertension, there are only some of them that you need to refer right away, like such as PVOD or PCH. These are two things that does not have any therapy medically, and you cannot even use it. Because if you put patients on vasodilators, these patients will go into having heart failure, right? So you cannot do it. So PCH, pulmonary capillary hemangiomatosis, and PVOD are the two common indications that you need to refer as soon as you diagnose them. Otherwise, they need to be on medical therapy. If they're not on maximum medical therapy or starting to be on it, then there's no point of doing so. Some patients, they refuse, like, I don't want to be on IV therapy. I don't want to be injected subcutaneously because so-and-so is so cumbersome, it's painful. Those are not the one we're going to be evaluating because that tell us their compliance is not that great. CF, this one has died down a lot since the arrival of Trikafta, because if you put patients on Trikafta, you even have one mutation of your regular delta F508, then you are qualified for the Trikafta, and therefore usually you have better outcome and you don't need transplant. However, to me, I think it only gonna delay your risk of progression anyway. Typically, we see patients with CF around their 20s to 30s for transplant, but with Trikafta, I think we can push it up to like 50 years old or something. So you might eventually start seeing them when they're 50 years old, which is not now. Maybe in 20 years from now, you start seeing CF requiring a transplant. But there are things about CF you need to know. Those who are female, they progress faster than male. If you have hemoptysis that require embolization, you should think about transplant right away. It doesn't matter if you're on Trikafta or not. If you have pneumothorax, pulmonary hypertension, these are indications for referring to transplantations. If you have exacerbation that requires BiPAP even once, and at the time of discharge you don't require BiPAP, that also is another indication for referral. If you start having more exacerbation that has nothing to do with your compliance, that also is another indication. If you start having organisms that keep becoming more and more resistant, that is another indication. So these are typically things that fellow usually miss, and they don't know whether we should be referring, because at the time when the patient's discharged from the hospital, they are doing well. They're doing well, they don't have problems, they come off BiPAP, they feel good, and they're young, so they don't see the need for transplant. but actually those are your red flags that you should be aware of. There's one organism which we cannot transplant. It is called Burkholderia cenocepacia, or Burkholderia genomovar 3. Because if we transplant these patients, they will have recurrence of organism despite their antibiotic sensitivity. At least 50% will recur at 1 year after transplant, and to eliminate them, it's not easy. And it associates with poor graft function as well. So typically, most of the program will not be transplanting these patients who have Burkholderia cenocepacia or genomovar 3. So these are things you should be aware of in terms of CF. Other bronchiectasis, usually we start thinking about them when you start having more exacerbation or when you're on oxygen therapy, that you can refer them to transplant. For pulmonary fibrosis, which is the most common indication we do transplant anyway these days, IPF, you refer them at the time of diagnosis, even if they're not on oxygen. And the reason for that is because they can have a flare. You don't want to have patients who have a flare and you have to do emergent or urgent evaluations, put patient on ECMO, and the things will be a lot more challenging, because if you are requiring urgent evaluations, then it will be challenging for us to do all the evaluation, and also patient might not be ready mental wise as well. Other pulmonary fibrosis, it depends, because if it's autoimmune related, maybe you can use some medication to tame it down and that will get better. So typically those patients we'll wait until they try immune suppression, or if they start using oxygen, then we can think about referral. However, there are some autoimmune lung disease which progress a lot faster. Do you know which one that usually progress very fast, that we should think about, like, okay, we need urgent evaluation now, even if you are seeing them as an outpatient? You can type, or you can think about something.
I want to say scleroderma.
Scleroderma maybe, but it's not the fastest.
Like MDA5 dermatomyositis.
Yeah, MDA5 is the one that progresses very fast, and so if you diagnose it with MDA5, you should think about transplant almost right away. For scleroderma, I'm glad that you bring it up because it has a lot of issues. So number one, you can have pulmonary fibrosis from scleroderma, right? But you can also have pulmonary hypertension at the same time, primary pulmonary hypertension from that. And these two combined makes them very sick. However, what is important about scleroderma is usually when they have esophageal dysmotility, because it also can have fibrosis in their esophagus, and that causes very bad GERD, right? When you have bad GERD, that also means you can have rejection from things going down to your lung. So you don't want that. You want to do a Nissen for this patient. However, if they have very bad esophageal dysmotility, you do a Nissen fundoplication, then you have problem, because whatever food you eat through the mouth will never get past the Nissen, and therefore it gets stuck in your esophagus and then come back into your lung. Then you have aspiration pneumonia and followed by rejection. So these patients at the Brigham, it is a contraindication to moving forward with transplantation. However, in some other hospital, when they do transplant for these patients, they often tell the patient you need to be NPO for at least 6 months or even longer. You need tube feeding, which is another issue, because some patients, once they can breathe, the next thing they want is they want to eat, right? So you end up having to negotiate with them. If they start eating, they're going to rejection, and they go into multiple rejection, they have chronic rejection. So that's the problem. Because transplant for lung is the most difficult as compared to other organs. The reason is because the lung is the only organ that's exposed to the environment, right? You breathe something bad in, or you have acid reflux, you have post-nasal drip that goes to your lung, then you have immune reactivation and leads to infection and rejection. Since you have a lot of immune stimulation to your lung, you need a higher amount of immune suppression, which leads to more issues, because each immune suppression, when used at a higher dose, it results in complications or side effect related to it. So that's why the lung transplant is a lot more difficult than other organs, and also can have poor survival as compared to other organs as well. For instance, our median survival is about 6.5 years. Whereas for hearts, 10 years, kidneys sometimes even longer than that, because they're not exposed to any environment known to man, right? All right, so here are some contraindications you should be aware of if you're actively using any kind of substance, then we stop it. One that might come up here is the marijuana, because legalized, right? But if you have history of smoking, then we will tell you you cannot use marijuana, because there's no way that we can distinguish between smoking marijuana and edible marijuana, even if you have a marijuana card. So in that case, we typically tell them not to use marijuana, and we can check for it. But if you are not smoking and you use edibles, then what we tell them is that we can have you use it, but if you use it for whatever reason, it has to be stopped right away after transplant, because it interferes a lot with our medications. And if their symptoms are only controlled by marijuana, after transplant right away, they don't have marijuana anymore, and therefore whatever symptom they control, they will become uncontrolled. So typically I tell them to stop right away, because stopping them after transplant is going to be very miserable. BMI, if it's greater than 35, then the surgery is not safe. So typically we don't want to do that. Cancer, most solid cancer, we require 5 years of having no cancer at all. Meaning after you complete the treatment, let's say if you find breast cancer, you get mastectomy and radiation therapy, and it's all gone right now. You count from the first day of your last radiation treatment for 5 years, and you think about it. However, these days we have some exceptions, so most of the time we have to discuss as a group to see if this cancer we can move forward or not, such as a prostate cancer, because what we are afraid of is if you use immune suppression, whatever T cells are suppressing these cancer will be weakened, and therefore your cancer will come out again. So you don't want that. But there can be an argument, let's say, if you have prostate cancer, which is not typically immunogenic, you don't use immunotherapy for prostate cancer. So if you have very limited stage of prostate cancer, maybe you can go ahead and do a transplant even if you're not reaching 5 years. Or the most recent case at the Brigham is chordoma, which basically it is a cancer, chordoma, right? But the prognosis is very, very good, and sometimes they delayed radiation therapy. They can just cut it out and be done with it, and typically we can still think about transplanting these patients if the cancer is not immunogenic. If you don't know which cancer is immunogenic, you can look it up. Let's say, which one do you not use immunotherapy? Those are typically cancer that's not immunogenic. Okay, so these are things that we look for, and the rest of them we decided as a team to see if there's any surgical contraindication. You have a lot of minor contraindication, you lump it all together, it'll be very big contraindication for you to move forward as well. So those are things that you require to talk about in the team meeting. At the time of transplant, what we have to think about is you can go into rejection, and acute rejection, there are two things. One is cell mediated, which is actually a T cell process. So T cell will go after something that has MHC class 1 that's something that's not belong to you, and they will start attacking, right? So that called cellular rejection, acute cellular rejection. But there are also another rejection that's caused by antibodies called antibody mediated rejection, which is caused by preformed antibody. You have formed some antibodies and then you react to the lung that you transplanted. The example of this is if you were to transfuse the wrong blood group, you give a blood group A to blood group B patients. What happens is that blood group B patient, naturally they have antibody against group A, right? So that's called preformed antibody. And then what happens? You have massive cell lysis due to antibody, right? So if you were to have preformed antibody that direct against your donor, then you would not transplant that patient because you go into acute antibody-mediated rejection, which may manifest as hyperacute rejection. So when you connect the blood vessel in the OR, that lung will swell up and then you die. That's how bad it is. So to avoid these two processes, number one, what we can do is if you were to be in a perfect world, like you got some lung donates from your own clone or your identical twins, then you don't have any problem like this. But if it's not that situation, which most of the time is not anyway, you need to make sure you don't have any preformed antibodies. So first of all, what we'll do something called cross-match. Cross-match means you have the donor, you have sets of antigen, in this case HLA antigen, and you have the donor, and you have a recipient. Recipient have some antibody against HLA, and you look at them to see if there's any corresponding antibody against the donor's antigen or not. If there is, then we call that positive virtual cross-match. Virtual means we just look at it, look at the data. Now we have issue with this because we check the serum every 3 months for the HLA. So every 3 months we bank the serums of the recipient. So if you were to have something that caused you to produce antibodies, such as you receive blood transfusion, you have some kind of viral illness to your lungs, and then you develop a new transplant antibodies, then if you missed that period, you didn't catch that period, so that's going to be a problem because your virtual cross-match may be negative, even though you have antibodies. So if you were to have anything that stimulates your immune system, at that time, you need to do an actual cross-match, which is what we call prospective cross-match. So we actually get the cells from the donor and we mix the serum of the recipients together to see if there's any reaction or not. So this way, if there's rejection, then we presume that you will go into acute antibody-mediated rejection, and therefore we cancel the transplant. So this is to avoid antibody-mediated rejections. But after you get transplanted already, you can go into antibody-mediated rejection as well. So therefore, we need a medication to prevent that, which we'll talk about it. But there's also another way of rejecting the organ, which is T-cell mediated. So now you can rule out antibody-mediated rejection, or AMR, by doing a cross-match. However, for T cells, you cannot do any cross-match. There's no way to do a cross-match for T cell. You need an actual matching of the antigen, make sure they're not, both of the donors are actually the same, which unfortunately in lung transplant, we cannot get a perfect match, unlike kidney, because kidney, you can wait for your perfect match because you can be on dialysis for a very long time. For lung, there's no such thing as lung dialysis, right? You can be on ECMO, but you can be on ECMO in the hospital. You cannot take an ECMO home. Or you cannot come in for ECMO here and there. So therefore, this adds to another layers of why lung transplant is so difficult. So to prevent acute cellular rejection, you need an induction. Induction agents are something that we will aim towards T cells, as you can see on the screen here. And then we do 3 medication. At the Brigham, we do basiliximab, steroids, and mycophenolate as the backbone. But after you're done with that, you need to put patient on maintenance immune suppression as well. The backbone is actually calcium inhibitors, steroid, and cell cycle inhibitors. The best one that we have here is tacrolimus, prednisone, and mycophenolate. These are the best combination to prevent acute and chronic rejection. Anything beside this is not as good, such as you put patient on cyclosporin, azathioprine, and steroid. They're not as good, but sometimes we have to use it because you suffer a very bad consequences from tacrolimus or mycophenolate that you cannot tolerate it. Other thing that we can use are mTOR inhibitor, but usually we don't use it right up front because mTOR inhibitors delays wound healing, and therefore it can cause issue with anastomosis dehiscence. So it cannot be used within the first 3 months and until you are done with anastomosis issues. Typically, infection in lung transplant, most people will think about what's the common infection in lung transplant? Do you know which one is the most common lung transplant infection? This might be a trick question to you because I'm showing something. Well, let's see if you can think about these questions. Well, might be too difficult. So the thing is, a normal or a common infection is actually something that is causing infection in lung transplant as well, such as common bacteria, common virus, those kind of things. However, in lung transplant, what's special about us is you can have reactivation of herpes group virus. And if you don't know herpes, there are 8 types of herpes, right? And all of them stay in your system forever until your T cells are not be able to control the infection. Then it will be reactivated. The thing that we really hate are as follows. You can see here: zoster, simplex, CMV, EBV. These are things that reactivates. The EBV we cannot prophylax against them. The thing that we can prophylax are CMV, VCV, and simplex. And the duration of prevention or prophylaxis depends on your IgG zero status. So, for instance, CMV is the thing that we really hate because you can have very bad CMV reactivation and leads to acute and chronic rejection. So therefore, you need to prevent them. We look for typically what controls the CMV is actually a T cells process. You can check for T cell CMV immunity. However, it's a lengthy process, it's expensive, and it takes time. So we opt for checking CMV IgG because CMV IgG is actually easy to obtain. It takes 2-3 days to come back. It doesn't need any specialized equipment to culture the cell and see if you were to react with the CMV in different ways. And we assume that if you were to have CMV IgG, you would have CMV T cell immunity as well. So for this reason, we check for IgG only for these organisms. The thing that we hate the most is when your donor has seen CMV before, so therefore you have IgG, and then your recipient never seen any CMV before, so they don't have IgG. So when you transplant a lung that's full of CMV hiding in your cells to the recipient who will be immune suppressed, if you not prophylax them, they will be reactivated. If you were to have this problem, it reactivates 100% of the time if you don't give them prophylaxis within 6 months. So CMV, and is something that you have to do. Antibiotic and antifungal of choice depends on your institutions. So this one we don't need to talk about. But at the Brigham, for bacteria, we use cefepime and vancomycin, and we will also look at the donors and recipient data to see if there's any organism that we need to cover. Antifungal, also the same thing. We use mycofungin, which is cidal for some fungus, but also static for the aspergillus as well. PJP prophylaxis, this one is lifelong. For CMV, you can actually stop it at some point. For PJP, you have to be on lifelong therapy. All right, CMV reactivation, I think this one we don't have to talk about. It can cause a lot of things that you can read on your own. Other consideration, there are some organisms that might lead to chronic rejection, which is what limited the lifespan of your lungs. In this case, CMV, Pseudomonas aspergillus. Even though they're only colonizer, they can lead to very bad chronic rejection as well. So you better treat them aggressively if you can. All right, now we're going to shift gear towards what are the differences between the allograft and your normal native lungs. So for the transplant lung, we don't anastomose bronchial artery, and the reason for that is because it adds times to the surgery without any improvement of the outcome. So you don't have bronchial artery, which normally supplied you 2/3 of your blood supply to the lung, and is the high pressure circulatory system. Now you only rely on pulmonary circulation, which is a low pressure circulations, and therefore anything that disrupts the blood flow to your lung can cause issue with your anastomosis. So let's say if you were to have atelectasis, or you have consolidation due to pneumonia, you have fluid overload, you have mucus plug, therefore your lung can be consolidated. This will impair the blood flow to the anastomosis, because you have to remember the pressure, the perfusing pressure of the capillaries is only less than 5 millimeters of mercury, and in the veins a little higher than that, but it's still not as high as you would want, because if you have to traverse the area of consolidation, it won't get past that easily, and therefore anything beyond that will have issue with the ischemia. The new lung, we sever the lymphatic drainage So therefore, any fluid you give to the patient will go directly to the lung. Therefore, when you round on with transplant attending, they will always say, okay, we need to diurese the guy. We need to diurese, even though you're in shock, because the moment you give a lot of fluid, even though it improves your blood pressure, it will go directly to the lung first, and therefore you cannot breathe. And this is why we have to be thinking about this. If you were to have difficult explant, then you might disrupt a lot of hilar lymphatic drainage, which can cause chylothorax. And typically chylothorax, as pulmonary fellow, you always learn that you should not be draining it, otherwise it will cause severe malnutrition and everything, right? However, in lung transplant, you always come out with the chest tubes, which will always drain this thing. But not only it can cause malnutrition, chronic drainage of your lymph cause you to have very, very low CD4, and therefore you are immune suppressed. In this case, if you were to have chronic drainage of your chyle leak, you may have to check for CD4 level or something called immuno, which is basically CD4 response to stimulation to see how much ATP it produces. So if you have CD4 coming out and you stimulate it to see how much ATP produce, if it produces a lot of ATP, that means your immune system are still good and they're very active. You might need to increase your immune suppression, otherwise you might go into rejection. If you have immune cells that are not responding to anything, it will produce low ATP, and therefore it's not good. However, you don't use immunoassay alone. You need to use it with your judgment. Let's say if you were to have recurrent infection, you check immuno. If it's come back low, okay, makes sense to back off some of your immune suppression. However, you have a bunch of infection, you check your immuno is very high. And if you put patient on more immune suppression, you're gonna have more infection. So therefore you cannot use it alone. You have to use it based on your clinical questions. The new lung, they don't have nerve. We cut it at the area of anastomosis, which is within the first tracheal ring next to your first branch. So the right upper lobe take off within the first ring, you do anastomosis right there. So therefore, when you do a bronch for these patients, you always see the anastomosis on the right first. On the left, you will not see it because it's a lot deeper down. You have to bronch and go in a little bit before you start seeing it. What does denervation means to these patients? It means that if you choke on something and it get past the anastomosis, you will not feel a thing. So that's why we ask this patient to cough up here and there to make sure they don't have anything that gets stuck in your lung and become a pneumonia later. Pleural space on both sides, they're now connected, which means one infection in one lung can go into another. This is called buffalo thorax. Your vagus nerve is also cut. Your swallowing function issue, GI transit time, going to become an issue. These patients typically require pain medication, and we always want the patient to get a nerve block, so therefore we can limit it, fentanyl or other narcotic use. If you use them a lot, then you have poor GI transit time on top of your vagus nerve issue, and therefore you have a lot of constipation that press on your diaphragm, causing lower lobes to be atelectatic, right? And atelectasis means poor perfusion, and therefore you have anastomosis issue. So therefore you're gonna start seeing us say, you need to poop today, otherwise we will not increase your feeding, right? Phrenic nerve damage is also another issue that we can see. Usually it's temporary and it will go away by itself. However, some patients do have prolonged paralysis of your diaphragm as well. Recurrent laryngeal nerve, especially on the left side, is also a problem because sometimes we have to clamp the aorta in order for an ECMO machine to be deployed centrally. And that will cause left vocal cord paralysis. So if you were asked which vocal cord usually get paralyzed, it's always on the left. All right, so there are a lot of complications that you can think of here, but what I would like you to know is this one, the vascular anastomosis, because if you do have issue within the vascular issues, then you would have issues that your lung would not survive. So pulmonary artery compromise, this is the problem because it can cause whiteout of one lung. Both issue, either artery or veins, can cause whiteout of one lung. The artery is whiteouted because you have pulmonary ischemia. But for veins, if you have blockage or something, then you have whiteout of the lung because pulmonary edema. So these are differences. You need to know how to look for these right away. Otherwise, if you let it be, then your lung will not survive. It can cause necrosis of the lung. So these two, for pulmonary artery, your lung will look dry. You bronch them, they're going to look dry. They don't have a lot of issues, but they have hemodynamic instability because you don't have enough blood flow back to the heart that you need to pump. And for pulmonary vein, it's always going to be pink frothy sputums or secretion that comes out a lot, and chest tube on that side going to put out a lot. That's considered pulmonary veins issues. Both of these are actually a structure that might get compromised very easily. Let's say if you need a lot of, the typical situation would be you have a difficult explant, you bleed a lot, and therefore you need a lot of fluid transfusions, right? And therefore your lungs swell up. When your lungs swell up, you cannot close the chest, because if you close the chest, you cause a lot of compromisation to all of these structures. And therefore you need to leave the chest open with a vacuum on. And what you do next is you said no heparin at this time, because if you give heparin, you might bleed more, right? When you have to do this and you end up having to put a lot of packing, come to the ICU, this patient is the highest risk of having PEs blocking these vessels, especially pulmonary artery. So if you were to have any doubt that your pulmonary artery might be compromised, you need to check with the CTA right away. Otherwise, if you let it be, your lung will be infarcted and then you lose the lung. Airway complication only happens if you were to have ischemia or infections, so treat these very well. You might have a fancy thing here. It's called vanishing bronchus intermedius syndrome. This is the most severe thing you can ever see when your anastomosis is compromised by this severe ischemia. Meaning when you bronch, you don't see bronchus intermedius at all. It's like all closed up. And this is a nightmare for IP guy to try to open it back up. Outer mental status. You know about PRES. PRES actually is caused by tacrolimus, especially at a higher dose. If you were to suspect PRES, you need to change the anti-rejection from tacrolimus to cyclosporin. Even though cyclosporin can cause PRES, but cyclosporin has less side effect with the with the CNS. So you have a lot of side effect from tacrolimus, usually like tremor, neuropathy, or even you have orthostatic hypotension that can also be caused by tacrolimus, especially someone who is very, very resistant to other therapy. Then tacrolimus switch to cyclosporin might be something you would consider. TMA, this is also another thing that you might think about. It looks like TTP-HUS, but it does not present like so. So it has nothing to do with Adams DS13. It's actually caused by the tacrolimus and cyclosporin again. So you start seeing a lot of schistocyte periphery, you start seeing renal dysfunction, and so on. So you look for hemolysis and peripheral smear. You start seeing that, then you switch the medication over from tacrolimus to cyclosporin and hope that it will get better. Typically, it will get better in the next 2-3 days. And this can happen at any time after transplant, even years after transplant. It can still happen even though you're on tacrolimus for a very long time, but usually it happens early on after transplant. This one is more specific to lung transplant, hyperammonemia. Usually it's caused by urea splitting organism, and these organisms are not easily to be detected. It's not easily culturable. So when you think about patients who have hyperammonemia, which you're typically going to test from day 3 to day 10, then you check for PCR from different sources like blood, urine, chest tube output, wound, and everything, and you treat them right away. You don't want to wait until you have a confirmatory test come back. You treat it with doxycycline, levofloxacin. Typically we do both just because there's a chance that one might be resistant to another. And if your ammonia start to rise beyond 200, you need to do dialysis as soon as you can. Otherwise, you have cerebral edema, and then you have herniation, and you pass away. In very rare instance that you have the PCR that comes back negative, you can still have issue with minor urecycle defect that got flare when you are stressed with the surgery and everything in the ICU. That's pretty rare. and usually it improves over time because after transplant for a while, your stress to your body goes down and therefore it usually gets better. PGD, this is more of the reperfusion injury that happens within the first 72 hours and it looks like pulmonary edema, but it's actually not. So you need to rule out fluid overload first before you call it PGD. If it happens, it can carry forward beyond 72 hours. But if you are transplanted 72 hours or more ago and you start having pulmonary infiltrate that looks like PGD, that's not PGD. Okay. The side effect you will learn a lot later on, so I'm going to skip this part. These are outline of the rejection. You have antibody-mediated or cellular rejection, but chronic, as you can see here, that can also be a problem. ACR is something that you're going to be doing a lot of bronchs. And the reason for why you get a lot of bronchs on transplant is to detect this guy, the ACR. So when you do a bronch, you're going to look for acute cellular rejection, which are T cells that cuffed around the blood vessels and the airway. So the more it is cuffing around that, the more severe the rejection is. One thing you need to know about this is it can cause eosinophilia, either in your BAL, your blood, or your pleural effusion. So differential diagnosis of hypereosinophils in lung transplant includes acute rejection, and it usually is a severe one because ranging from mild to severe rejection, eosinophils usually happen when you have severe rejection. So apart from you have allergy, drug issues, fungus, worms, something like that, ACR is another reason for you to have eosinophilias, and you should think about it. And the treatment of ACR is something to do with T cells. So anything that you can do to deplete T cell, that works on ACR, and usually the outcome is good. But the AMR, this one is very difficult. And the bottom line of this is try to eliminate the acting donor-specific antibody in this case. So you use plasma exchange to get it out. And you can use IVIG, which work in two different ways. So number one, it kind of tells your body that you're making too much IgG now, let's stop making by giving a ton of IgG in. And second way is to saturate the receptor for the antibody. So you have FC receptor at the end and FAB, right? FAB binds to the donor cells. FC receptor is something that other cell, which is the effector cell, will come after. What if you give them a bunch of FC receptor and saturate that receptor, and therefore it will not come by and bind to the donor-specific antibody against the lung. So therefore it kind of reduce the inflammation to the lung. You can do that as well. Or you can use other modality. Let's say you can stop B cell from producing something, give rituximab, you give plasma cell agents such as bortezomib, carfilzomib, or so on. So these are things that you can do, but we don't have standardized protocol anywhere in the United States or in the world to treat AMR. So it's a case-by-case basis, but the bottom line is to understand this concept of how to treat it. For chronic rejection, typically you see this in an outpatient. You need to establish a baseline FEV1, which is the highest FEV1 done at least 3 weeks apart after transplant. Your FEV1 usually peaks around 6 months after transplant, but it can take about up to 1.5 years to peak. FVC typically peaks a little bit later, like a year or two afterwards. So in the first year, you might have to recalibrate your peak FEV1 every now and then because your FEV1 is still going up, right? So you average the two, that is at least 3 weeks apart as your baseline, and you see if it decline from that. If a decline is more than 20% that persists more than 3 months, that's considered a definite chronic allograft dysfunction. Then you start thinking about what next, what actually caused it. You don't wait until it drops. You drop 10% from your baseline, you start thinking about you have infection, you have rejection, you have anything else that could explain that, you gain weight, you have pulmonary edema, those kind of things. Once you confirm everything and you think it's this guy, then there are treatment that you can do, as you can see down here. But we will not be going to the details that much. we see more bronchiolitis obliterans syndrome than RAS. The BOS is something that you can have obstructive physiology. Your chest CT scan with inspiratory and expiratory sequences will start seeing air trapping, but no infiltrates. This is the major difference between BOS and RAS. RAS will have infiltrate that look like pleural parenchymal fibroelastosis that start from the top and go down to the lung. That's your RAS. If you see BOS, you don't see that, but you see air trapping. Okay, BOS has better prognosis than RAS, and if you do a redo transplant, BOS also have better survival than RAS. So if you have the new lung transplant, your survival rate is good, and your median time is 6.5 years. For BOS, it's about 3 years after redo, and RAS 1 to 1.5 years after redo. So you have to think about this very carefully of whom you're going to do it, because usually you do this redo transplant when you are older, right? You're on transplant for a while and then your lung failed and you think about doing redo transplant. So usually you have a lot of issue from complication from transplant the first time and medication issues, especially the kidney issue, which we'll see a lot. Cancer is going to be more common in lung transplant. Skin is the most common cancer you see after transplant. PTLD caused by EBV mismatch. There are a lot of treatment for that. EBV mismatch, if it happened in the first year for PTLD, usually have better prognosis than when it happens later, because early on it's usually polyclonal and you can reduce your immune suppression, give rituximab, and it usually goes away pretty easily. However, if you see them after the first year, usually it's clonal. It's not polyclonal anymore. It's monoclonal, and it's going to be more challenging to get rid of it. One thing you need to be aware of is CF, because CF itself increases the chance of having colon cancer. So screening for CF, instead of being, you're going to take medicine board exam, right? So these days, instead of having screening colonoscopy at 50 years old, you do it at 45 years old. But for CF is 40 years old, regardless of your family history. All right. But anyway, if you have family history of cancer a lot sooner than that, you have to do it even before 40s. And if you have CF that get transplanted, their chance of having colon cancer go way up. So if they're older than 30 years old, they get lung transplant, they need a colonoscopy within 2 years after their transplant. So this is the differences between the regular transplant and the CF that you need to be aware of. Sometimes you see primary disease that recurs. As you can see here, I put them in red. Sarcoid is very, very common that it recurs after lung transplant. But usually all of these, when even they recur, does not need any treatment, does not portend poor prognosis or anything. So you can rest assured. But when you do a bronch, say, hey, I see granuloma in there. Is that something? No, it may be the old disease that comes back, but you don't have to do anything. And as for the alpha-1, some of you may have think about, okay, should I be using prolastin for enzyme supplementation or not? The answer, I will have you think about it like this. How old is your usual antitrypsin patients? If you start seeing patients who have alpha-1 antitrypsin patient in their 30s or 40s, well, you don't see them within the first 10 years, right? As I mentioned to you, the median survival is 6.5 years, but so giving them prolastin might not be something useful. It might take them 30 to 40 years to develop alpha-1 issues with the lung, and those patients usually are smokers. And if you're not smokers, you get lung transplant, you should not be having issues within your time frame 10, 20 years, probably 30 years maybe, right? So typically we don't use that for that instances. However, it may be useful for those who have skin disease from alpha-1 antitrypsin. Enzyme supplementation does not treat liver disease. Remember this, because most people, I don't know why they don't know, but it does not do anything with the liver. The only issue with the liver is those who have PIZZ, which their enzymes are misfolded and get stuck in the liver and then cause liver injury and therefore liver problems. It's not because you don't have enzyme. it has misfolded enzyme. So you have misfolded enzyme, you give more enzyme from prolactin, it's not going to do you any good. So therefore, even if you have liver issue, giving prolactin or enzyme supplementation therapy does not do anything. Okay, so I'm going to give you this question and see if you can come up with the answer. So who should we be sending for a transplant? All right, you can all chime in. So the first one, I'll read it out. So 55, COPD, a lot of hospitalization, hypercarbic issues already, quit smoking 5 years ago, BMI of 42. Do you think you can transplant the guy? All right. This one, I don't think anyone's gonna start saying yes or no. For B,
There are some comments on the chat. Michael and Max was saying BMI is too high for transplant for A.
Yeah, BMI is too high, correct. And for B, it's 28 CF, recurrent hemoptysis, a lot of embolization treatment already, severe depression, anxiety, and non-compliance to medications, colonized with MDR, Pseudomonas, and Burkholderia Synosiphagia. Should we be considering these patients? Burkholderia is a contraindication, Brigham. Burkholderia alone is not a contraindication. It has to be Burkholderia Synosiphagia, as I mentioned to you before. So there are several genomovar, like 7 genomovar or something, but only genomovar 3 or Synosiphagia is the one that we don't transplant. All right, so that's that. And also the chance of this compliance issue will be something that you have to think about as well. For C, 32 with IPAH, who is on ibuprofeno, tadalafil, mesentan, and then still not doing well, BMI 30. Do you think this one we can do it? Yes, I just give you the answer. All right, the last one, obviously, you have 64, stable and intended, was diagnosed with cervical cancer, underwent a hysterectomy 1 year ago without any recurrence, still within 1 year, so you don't typically do it. All right, so this one might be a little bit long. So we see 35, male with CF, who was transplanted 3 days ago bilaterally. Some of you may have asked, like, who get 1 lung, who get 2 lungs. Typically, if you are young, you try to get 2 lungs. But those who are older, if you can give 1 lung, then will be great. Who cannot get 1 lung? Those are patients who have severe pulmonary hypertension or actually pulmonary hypertension, because if you transplant 1 lung, then that lung will get a lot of blood right away. It might fail right off the bat due to high pressures. Patients who have bronchiectasis or infection on both lungs, because the old lung, if it remains there, it can spill over the issues to the new lung. And those who have something that you are following up as a nodules, you have to cut it all out, otherwise you leave the cancer in and become a problem down the road. Another thing that we have to think about is COPD, because those who have severe COPD and emphysema, you cut out 1 lung, that old lung is going to be hyperinflated and then cause compression on the new lungs, and then the lung function might not be that great. All right, so let's come back to this case. Patient was on ECMO while for transplant, has a lot of bleeding there, chest left open, wound wax on. He's CMV negative, received lungs from CMV positive donors, so high risk, right? Patient still requiring vent support due to hypoxemia, chest x-ray to diffuse infiltration on the right side, left is good. Bronch with intact bilateral anastomosis, scan secretion, pale mucosa on the right. Donor screw, MRSA, E. coli, currently on tacrolimus, mycophenolate, prednisone, ganciclovir, Vang, cefepime, not on anticoagulation due to bleeding. What do you think we should be doing for this guy? Have to run to clinic. Good luck, man. All right. What do you think we should be doing? This is anastomosis issue with the artery. So pulmonary artery can cause pulmonary infarct, which can cause that lung to be white out and dry. And in this case, it's dry. Infection, well, you already control with the medication you gave up there. Biopsy is not going to tell you anything. Antibody against HLA does not cause rejection in one lung. Rejection has to be two lungs, so you cannot have infiltrates in one lung only. Go up on the methylprednisolone, do anything, because this is not rejection process. All right, so I think that will be all. You guys have any questions or anything?
Thank you so much, Tanny. That was very helpful.
Well, no worries. You get well soon, and then once you do transplant, it's going to be something you have some more questions about.
Yeah. Great. Are you coming back anytime to Brigham or
No,
any
sure
other
yet.
lecture?
Not sure yet, but we'll see. But not in the meantime. But if you need anything about learning or anything, just ping me. You have my number already.
Yeah.
So just let me know.
Great. Thank you so much.
All right, you take care. Get some rest.
Bye.